Thank you for inviting me on this prestigious conference. I think Dr. Farzana has given the nice introduction. So this is my journey from Nishta to PKLI. It's complex, but it's a successful journey. Uh, so my talk is a hybrid talk. It's both diagnostic and intervention radiology. So I'll talk about a bit of ultrasound, renal tract, and some introduction to intervention radiology, because that's my specialty. I'm working for a long time in intervention radiology, and I want to talk about intervention radiology to give an idea what exactly we are offering in IR. So in case of genitourinary or renal tract ultrasound is the basic modality, or you can say in these days it's a screening modality. We use grayscale and color Doppler ultrasounds. When you are examining the patient or performing, so there are different positions. You can do the scan in a supine position, lateral position, or sometimes even prone position to localize the kidney. The location is the mid-axillary line, just below the costal margin. You can scan in both longitudinal and transverse sections, and make sure when you are doing longitudinal, go both anterior and posterior to cover the whole kidney, because the pathologies at the margins of the kidney you may miss actually. And similarly, when you're doing transverse scan from the top to bottom, actually from the upper pole to the lower pole, because anything which is exophytic is lying outside, you may miss that. So this is my, you can say, way how we do the ultrasound actually. So this is how the kidney appears on longitudinal section. You can see there is a liver here, and this is the kidney, and this is the midsection kidney thing actually. So you can see the cortex all around at the upper pole, lower pole. This is the renal sinus. These are the pyramids, and then is the cortex actually. So renal sinus and the cortex. So you can see the anatomy very clearly here. And this is how we take the bipolar length. This is the left kidney. You can spleen on the other side, and then more or less the anatomy is the same. These are longitudinal sections. And this is the comparison between longitudinal and transverse section actually. And you can see this is the longitudinal section here. You can see very well the kidney from top to bottom. And this is the transverse section. You can see kidney from anterior to posterior. And this is the hilar level actually. So from the hilar you can go up and then go down to scan the whole kidney to find the pathologies. This is how we take the measurements actually. That's very important. Bipolar length, then is the cortical thickness and parenchymal thickness. Parenchymal thickness also includes the pyramids actually. And then is the central echogenic sinus. Common pathologies, I will just show you some pictures of common pathologies. I will not go into the lot of, you can say, the details or the discussion. You commonly see the stones in kidney. Keep in mind, any echogenic thing is not the stone unless it gives you a acoustic shadowing, and that's a very neat and clean acoustic shadowing, because the ultrasound waves are stopped by the ultrasound actually. So you can see the black thing at the back of every stone. So this is how you differentiate between stone and other like air and fat in the sinus. This is another example of Staghorn calculus. You can see stone here, and then is the shadowing here. You can see stone here, then is the shadowing here, and this is, so it's covering all the calyces. So it's a Staghorn calculus on ultrasound. This is, so you have to differentiate between the stones and the nephrocalcinosis. So if you look at the stones are in the major calyces, and this is pyramidal calcification. So the nephrocalcinosis are more towards the cortex or towards the surface of the kidney, and then is the patient history. And the age of the patient is really important. Next thing which we commonly see are the renal masses actually. Those renal masses can be exophytic, can be endophytic, or can be large or small. If you look at, this is the loss of parenchymal texture, and there is a bulge at the surface of the kidney. That's the mass actually, that's the exophytic mass. So they can present as a bulge of the kidney, they can present as a bulge on the renal sinus, or they can replace the major part of the kidney depending upon what exactly the size of the lesion is. Hydronephrosis, you commonly see renal stones and hydronephrosis. So anything, if you see just I normally grade from mild, moderate to severe. There are 4 or 5 grades, but I think that's clinically not very important. If you look at, you can see something black here. These are the dilated calyces. These are a bit more dilated, and these are then rounded up. So this is mild, moderate, and severe hydronephrosis. When you are scanning, if you scan laterally, you can scan the top of the ureter because the rays are coming through the kidney, so you can easily see the stones at the upper ureter, and similarly, if the bladder is full, you can see the stones at the vesico-ureteric junction when you're looking back. This is another example of mass where the mass is replacing almost everything, and you can see something heterogeneous structure which is not following the normal anatomical patterns of kidney. Another mass which you sometimes see, which is a benign actually. So this is a fat density. If you look at this density and the density on the previous section, that was heterogeneous, and this is homogeneous. And if you compare this density with the subcutaneous fat, it's more or less similar. So these are angiomyolipomas. Angiomyolipomas are benign tumor, but they can bleed if the size is more than 4 or 5 centimeter. So we can offer embolization in such cases to avoid the catastrophic bleeding in such patients actually. Then cysts, you normally see in patients actually, cysts are hypoechoic, are echopenic things and show posterior acoustic wall enhancement. This is how we label the cyst as a simple cyst. So the cyst can be complex. So we have a Bosnian classification, which is a CT classification. I will not go into the details. So please do mention any septation, any nodularity, any soft tissue component, because presence of such thing is suspicious and for malignancy actually. And we can do CT for that case to confirm the presence or absence of malignancy. Post-trauma, you can see sometimes perirenal collections. And this is, if you look at, this is heterogeneous area, which is subcapsular. And this is the renal parenchyma, which is compressed, and you can see the sinus here. So this is some kind of page kidney in case of trauma actually, and this can cause sometimes even the transient hypertension in such patients actually. So then is the renal parenchymal disease, very important actually. So renal parenchymal disease presents with the size of kidney goes small and the echogenicity. So the one thing which we normally look at, that's the corticomedullary differentiation. So if it's getting you can say blood, so this is the renal parenchymal disease in a clinical settings. Size of the kidney sometimes doesn't matter, because sometimes the kidneys are normal size, but still there is a renal parenchymal disease. Echogenicity is the most important factor. Then there are certain conditions where the kidney is swollen. So you can measure the size of the kidney, that's usually larger than normal, couple of centimeters. And if you look at even here, the corticomedullary differentiation is gone actually, but the kidney is swollen. Then the bladder evaluation, so you always evaluate in longitudinal and transverse section. This is the transverse section, this is the bladder, and this is the prostate at the bottom actually. You can do the longitudinal section, look at the bladder, then the prostate in a longitudinal way. Then is the prostatic measurement. You can do AP transverse and the longitudinal. You can calculate the volume. This is normally done by the machines itself, and always do post-void volume in cases of prostatic hypertrophy. On Doppler ultrasound, you can see ureteric jets just to exclude the obstruction, and this is how the bladder wall thickening and trabeculation appears on ultrasound. This is the diffuse wall thickening, and then is the focal wall thickening. This is how the bladder masses are projecting into the urinary bladder lumen. So sometimes you can see the hematomas, but there is always history of hematuria. This is how the prostate looked like on transrectal ultrasound. So the probe is placed transrectally, and you can see the prostate, which is quite enlarged and hypervascular. Then is the scrotum. I'm mentioning scrotum because there are certain conditions which are very critical to find actually. So always do transfer scan to see both the testes to confirm that both are present. Then is the epididymis. This is the normal parenchymal texture. The next thing is the testicular torsion, which is very important to save the testes. So if you look at, is the absent flow on this side and heterogeneous appearance, and then the flow is on the other side. You can see very well. And this is how the architis presents actually. So here the flow is more. So when you evaluating the scrotal pain, keep these things in your mind actually. The next part is the intervention radiology. Actually, the vascular intervention radiology offers pinhole or microsurgery, no big incisions. So mostly 8 of 10 procedure, we have only 5 millimeter incision, and most of the procedure are done under local anesthesia as day cases, so patient can go out same day, and few cases are done like the next. So no large, you can say the surgical incisions or procedure. So this is one of the example of the minimal invasive surgery, that you can see a big pseudoaneurysm, traumatic pseudoaneurysm, and we can place this stent percutaneously with a small hole. And if this ruptures, the mortality is 100% in such cases. What we offer like we treat cancers like liver cancer, we treat kidney cancers, we treat even we can do like RFA and microwave ablation of renal cancers. We treat aneurysms. We treat internal bleedings like GI bleeding, post-trauma bleeding. We also treat blocked arteries like peripheral vascular disease, DVT, pulmonary embolism. We do prostate embolization, which is a very nice, neat and clean, single-day procedures, no bleeding. We do fibroid embolization. We do varicose veins, dialysis access. We do like bone tumor ablations, and we also treat the vascular malformation. I will show you a few examples of the procedure which we did actually. So this is the right common iliac stenosis. So we put a kissing stent in this side and everything is open. So the patient had a claudication, he can't walk, and the next moment is everything is fine, and then this image. Then is the renal artery stenting. That's another important thing. So if you look at this, the renal artery, this patient had bilateral renal artery stenosis. So we put the stent on both sides, and this is how it appears after stenting. So it's better, it's to control the hypertension where the renal artery stenosis is there, and you're giving plenty of antihypertensive as patient is not responding. We treat liver cancer. This is one of the example of a transarterial chemoembolization. This is the splay, and this is the tumor. We have injected the chemoembolization, that's the lipoidal and doxorubicin, and the results are always good in such cases if the disease is limited. We do RFA and microwave ablation. This is one of the case where we did, this is the lesion here. We did microwave RFA ablation in this case. This was another lesion. So it was gone completely on the next CT. We do sometime treatment of benign conditions, like this is the case, we do liver hemangiomas. Symptomatic liver hemangiomas can be treated with transarterial chemoembolization. We are running a series of such cases. The symptomatic patients are treated with bleomycin and lipoidal, and the results are really excellent. They don't need surgery. And we have treated like 15 centimeter large hemangiomas. We can treat like portal hypertension with TIPS, that's the transjugular intrahepatic portosystemic shunts in cases of CLD. We do renal tumor microwave ablation or RF ablation. If you look at, this was the tumor here, and this was ablated with the microwave. So this patient had a single kidney, and she had two tumors. One was at this point, and the other one was at the bottom, which I haven't shown here. So we did RF microwave ablation in this case, and the patient did well, and she is without any renal replacement therapy. Prostate artery embolization, as I said, is a really nice procedure, neat and clean. We do angio, we embolize the thing, and patient can go home same day. So the results are equally good. Even I will say, because the recurrence, if successfully done PAE, the recurrence rate is much lower than TURP actually. And you will not have any catheters, any bleeding, anything from this, this kind of treatment. Fibroid embolization is other thing which we normally do in patients where they have the bleeding or pain or infertility. We can do fibroid embolization. It's again the same way. We come into the uterine artery, we block the uterine artery, patient can go home next day, and the results are equally good, or even better, because there is no scars, no hospital admissions, no post-op complications. And lastly, we do a lot, but because of the time thing, I kept it like shorter. So we offer in patients where the osteoarthritis is not responding to painkillers or routine painkillers, we can offer genicular artery embolization, and this genicular artery embolization in OA, especially knee joint, has really good results. So there is a lot to say about the intervention radiology. This is my hospital. But I kept the things short, so I want to give you a taste what exactly we can offer. And thank you very much. I think this was all from my side.